Good evening, everybody. I am Antonella Dogani, a perfusionist from Italy, and good evening, European perfusionist. Italian Perfusionist Association, ITFEP, together with the European delegate Maria Erminia Macera Mascitelli, have been present in EBCP since its foundation in 1991. Sharing the mission of education in perfusion practice in order to improve its quality. For this reason, we thought about to address a well-known subject like cardioplegia and its integration in cardiac surgery practice. And we will deal with the cardioplegia in pediatric cases and adult cases regarding the nidocardioplegia. And if you have a question for the speakers, please feel free to write in the questions and answer in the toolbar. And it's a very pleasure to introduce the first speaker, and Erminia Macera Mascitelli, ECP delegate in the perfusion in Italy. Please.
Thank you very much, Antonella. Good evening, everyone. It's a pleasure and honor to introduce the 50th edition of the EuroFusion webinar series hosted in Italy. The title of my presentation is a Perfusion in Italy. Italy, in addition to being the cradle of heroes, poets, artists, was also the home of many scholars and who contributed significantly to the birth and the development of modern cardiology and heart surgery. From Galeno, who influenced the medical knowledge for the next 14 centuries with his pneuma, through other doctors or scholars, such as Mondino de Luzzi, Leonardo da Vinci, who wrote the most famous treatise on anatomy of history, Giovanni Maria Lancisi, and many others. The development of cardiac surgery has been very slow in Italy because the heart as an organ has for centuries been considered the seat of feelings, and there has been a widespread belief even by academic authorities of medicine that nature had placed the heart behind the limit of surgery. At the end of the 19th century, for the first time in the history of surgery, a surgeon, Guido Farina, performed a direct suture in the heart in a patient of 30 years. So, the first decades of the 20th century, this advanced allowed surgical treatment of some heart disease. In Italy, Pietro Valdoni performed the first pulmonary embolectomy surgery in 1935, the first in Italy and the 9th in the world, and in 1951, Doiotti and Actidato performed the first mitral commissurotomy, and in the same year, the first extracorporeal circulation in human. In those years, the cardiac surgery was born as a branch of general surgery, and with the advent of the extracorporeal circulation and increased reliable and safe techniques, cardiac surgery had the development. In 1964, Giuseppe Cevese carries out the first intervention in Padua. In 1985, Professor Gallucci performed the first heart transplant in Italy, and 4 years later, in 1989, Carlo Marcelletti performed the first pediatric heart transplant. So, among the many personalities of that time, a pioneer of the modern perfusionist was Pier Ferdinando Mondello, a mentor who trained many young perfusionists. Until 1973, the perfusionist activity was carried out by surgeons and nurses. In 1973, the first university school was born in Rome. In 1977 in Verona, and after in Chieti, Genoa, Milan, and Siena. On the years, the degree course was updated, and in 2001, the degree course is officially named Cardiocirculatory and Cardiovascular Perfusion Techniques. Actually, we have 107 cardiac centers and 12 degree courses in Italy, distributed through the national territory. Degree courses are recognized by the Minister of Education, University and Research, and related to the Faculty of Medicine. The programs of the degree course are the same and follow the same guideline both for admission to degree course as well as the teaching program and the final exam. To be admitted to the degree program, the student must hold a secondary school diploma. The number of places is set annually by decree of the Minister of Education, University and Research, and the admission to the degree programs take place through a competitive examination. The course offers theoretical and technical preparation in various sectors of the health area, such as cardiology, heart surgery, pulmonology, intensive care, and the first aid interventions. At the end of the course, the graduate will be able to perform most of the instrumental cardiology diagnostic procedure, such as echocardiography, electrophysiology, instrumental control of a pacemaker device, and automatic impedable defibrillator, cardiac telemetry, and telemedicine tools. And in the field of cardiac surgery, the graduate will be able to independently manage of extracorporeal circulation method as a support to cardiac surgery or as a cardiocirculatory and respiratory assistant in patient with cardiac or respiratory failure. Graduate will learn to make decisions consistent with the legal, ethical, and deontological dimension that govern healthcare organization and professional responsibility. These skills will be provided during the course through the study of fundamental of biomedical, knowledge of interventional cardiology, vascular diagnosis, pulmonology, thoracic surgery, cardiac surgery, and forensic medicine. And an intense tutoring activity is foreseen which for some activities. To complete the practical training activity, simulation sessions for extracorporeal circulation and medical circulation assistance are provided. In this session, the students are educated not only to manage technical problems, but to develop non-technical skills such as team working. Our association has been a member of the European Board since 1991 and has always agreed on the mission in order to unite European perfusionists in their desire for equality of standards in both training and professional status. We have always felt that the continued education of the perfusionist is important, and the training is an indispensable requirement to carry out professional activity. Also, training plays a strategic role by providing appropriate responsive in the care pathway to the knowledge and skills needs of healthcare professionals. And training must be maintained and certified, and the maintained revalidation of skill represent the added value of each professional and of the entire health system. To improve the skills, the performance, and the outcome. I would like to conclude my presentation with the words of Nelson Mandela. Education is the most powerful weapon which you can use to change the world. And also, I want to remember the Ukrainian people and our colleagues. You are defending not only their country, but also the freedom and the democracy of all over Europe. Thank you.
Thank you so much, Erminia. Very, very interesting, the situation in the perfusion in Italy. And now I'm very proud to introduce the second speaker, is Dr. Mauro Renghini, extracellular del nido cardioplegia in adult cardiac surgery. Please, Mauro.
Thank you, Antonella, and thank you to EBCP. I'm glad for this invitation. Okay. Please. Okay. I am Mauro Renghini, and I am a chief perfusionist of Ospedali Civili in Brescia, and I am a delegate of the Italian Society of Perfusion, and I work in a team of 7 cardiac perfusionists, young cardiac perfusionists, and we performed 800 cases per year of cardiac surgery. We are a hub for cardiogenic shock treatment and for respiratory pathology. But today I'm here for explain our experience with the del nido cardioplegia in adult cardiac surgery. How it should be the cardioplegia, with a fast and efficient cardiac arrest induction for minimize the ATP consumption, with a good myocardial protection to delay irreversible cell injury for global ischemia and limit reperfusion injury. Immediate reversal of cardiac arrest with heart rate and force of contraction for early weaning from cardiopulmonary bypass, and short half-life without toxic effects to other systemics after termination of the CPB. In the nido solution has been first used in pediatric cardiac surgery. The Dr. Del Nido and his group demonstrated that this solution was safe and reliable compared to other cardioplegia solution used in pediatric cardiac surgery. The Del Nido solution is more diluted compared to standard blood cardioplegia, made of 1 part of blood and 4 parts of crystalloid solution. This property facilitates cardioplegia delivery. Another important property is the reduced calcium paradox effect, because contains 75% less calcium, lowering of intracytoplasmatic calcium at the reperfusion, and contain also lidocaine as a membrane potential stabilizer. The solution can be stored at room temperature and doesn't require the cold chain, and cooled during infusion with heat exchanger at 4 degrees, and could be administered anterograde and retrograde depending on necessities of type of surgery. We use a customized cardioplegia circuit divided in one tubing of 1/4 size for delivery of the nido solution, and 1 tubing of 1/4 size for simple blood connected at the post-oxygenator bypass and performed with a twin roller pump. The nido solution was mixed with the whole blood in a 4:1 ratio and cooled 4 degrees through the exchanger. The blood flow pump is subservient to the crystalloid pump in the percentage of 25 to administer the 4:1 ratio. Our infusion protocol, an initial dose of 20 milliliter per kilogram, was delivered with a maximum of 1000 milliliter for patients larger than 50 kilogram. An additional dose of 500 milliliter was administered at 90 minutes if the expected ischemic aortic cross clamp period is over 120 minutes or there was a spontaneous return of electrical activity. Half dose of 10 milliliter per kilogram was administered for DAS procedure requiring an aortic cross clamping less 45 minutes in patients, but without left ventricular hypertrophy. Cardioplegia could be delivered both anterograde and retrograde. Anterograde in aortic root with 300 milliliter per minute of flow pump, or retrograde in coronary sinus with 200 milliliter per minute flow pump and the pressure of 20 millimeters of mercury. And in case of aortic insufficiency, direct administration coronary ostia. And this is our experience. Since we have introduced the Nido solution, we radically changed our myocardial protection strategy. The Nido solution was introduced in our institution in 2019 and representing less 5% of the use cardioplegia. But nowadays, as you can see here, the Nido solution was used in more of 95% of procedures. Our experience with the Nido solution is comprehensive of the population that we shown of 658 patients, and in the table are shown the baseline characteristics of our population. In 17% of the cases, the Nido solution was used during urgencies or emergencies, and in 5% of the cases in the reoperation. The Nido solution for myocardial protection strategies was adopted in all types of surgery, from isolated coronary artery bypass grafting to complex aortic surgeries. Repeated doses was necessary in 20% of cases, and after removing cross clamp, in 85% of cases, we observed a spontaneous recovery with sinus rhythm. We experienced the ventricular fibrillation in less of 5% of cases, and median time to recovery of a spontaneous rhythm of 120 seconds. Median cross clamp time in our population was 78 minutes. The myocardial enzymes levels from pre-surgery to third postoperative day. The troponin level after surgery showed a peak in the first postoperative day with a rapid decrease within the third postoperative day. Similarly, CK and B levels rapidly decrease from surgery to third postoperative day without a significant release after surgery. And this figure showed that there was no significant difference between troponin peaks for patients with different cross-clamp times. Similar to troponin, no significant difference was found in CK and B peaks for different cross-clamp time. The Nido solution showed a low positive correlation between cross-clamp time duration in patients undergoing coronary artery bypass grafting and in patients undergoing isolated mitral valve surgery. Similarly, patients undergoing for isolated aortic valve surgery. This is our results. Outcomes showed overall mortality 1.8% in all casuistic. Less of 10% of patients experienced the low cardiac output syndromes after cardiopulmonary bypass. But we defined the low cardiac output syndrome as the use of any type of vasoactive and inotropic drugs after cardiopulmonary bypass. We use the intra-aortic balloon pump in 5% of population, and ECMO uses in 3 cases. As well, 3 patients had the post-operative myocardial infarction. Instead, the median mechanical ventilation was 7 hours, with the median intensive care unit time of 24 hours. The use of del nido cardioplegia relevant impact on our daily activity, with a very low rate of adverse events related to a bad myocardial protection, and it could be safely used in all type of cardiac surgery in most of cases with a single shot of cardioplegia. Thank you very much.
Okay. Okay. Thank you, Mauro. It's a very interesting topics. It's very important to know this type of cardioplegia. And I introduce the last speaker, Dr. Mauro Cozza. He is a perfusionist of San Donato, and he talked about the strength of evidence in pediatric cardioplegia practice. Do you have any? Thank you, Mauro.
Thank you, Antonella, for the kind invitation. I join the endorsement that Armenia did before about our colleagues abroad in Ukraine. I would like to point it out some focus about the use of cardioplegia in pediatric population. There is obviously a paradigm when we face to the choice of cardioplegia in our clinical practice, and there are some key factors that we have to take care in understanding the myocardial protection strategy. First of all, what is ischemia or perfusion injury, and having in mind that the damage is induced when the heart is arrested, but it's aggravated during reperfusion. In pediatric, there is another 40 factors that we have to take care of. That is the pediatric heart more susceptible? Because we work with a high mature myocardium particularly in neonates and infants, and we face to also cyanosis in congenital heart disease. And by the end, talking about cardioplegia practice, we have again to take in mind that we should standardize any efficacy evaluation in terms of outcome variables. Either we're talking about clinical or outcome markers of outcome, and they should be reliable, and I can add shareable with other colleagues. I thank you to Mauro for the first presentation, because it introduces some topics about the idea of how ischemic reperfusion injury happens. I don't want to bore you, but just a couple of things to take in mind. As we told during ischemia, the cessation of oxygen supplies are mainly to negative effects. There is an increase of reactive oxygen species that product the major mitochondrial calcium uptake, and a loss of the ATP production that on one side gives an inefficiency to the ionic pump, and that by the hand lead to membrane potential lowering, and on the other side the gathering of hydrogen ion and lactate that lead to acidosis, and again the inefficiency to the ionic pump that doesn't work anymore in the correct way, leading to intercellular sodium accumulation with the sodium calcium pump exchanger deterioration that lead to calcium gathering inside the cells. On the other side, reperfusion has indeed a couple of negative effects, because again the low activity due to the ATP depletion in recover the membrane potential doesn't allow a correct repolarization in which we have the major calcium uptake due to the major mitochondria, and a reoxygenation that triggers again the reactive oxygen spatial formation. This leads in any case to calcium accumulation inside the cells with myocardial hypercontracture, a severe myocardial edema, myocardial damage. About the immature myocardium, we have to think that myocardial fibers in immature myocardium are less, with a greater stromal component. That means a fibrotic tissue that is not able to participate to contraction. The fibers are arranged in a chaotic and nonlinear pattern with a great length in baseline condition, resulting in a less diastolic reserve when we have a volume overload. There is a high myocardial cell density, but we have less vessels, and we have a smaller number of sarcomeres and mitochondria that impair the calcium storage capacity of the sarcoplasmatic reticulum. And by the hand, myocardial function is characterized by ventricular interdependency, in particular when we talk about overload in volume or in pressure. We have then remembered that in the immature myocardium, there is a reduced myocardial storage of catecholamine, so cardiac output depends much more from heart rate than preload and contractility, and it's more susceptible to parasympathetic stimuli that can modify heart rate. Metabolites of carbohydrates rely on, particularly on amino acid, in particular on glutamate, pyruvate, and lactate for the contraction. So this means that it's much more vulnerable to hypoglycemia, and this is reflected by the stores of glycogen and the reduced number of mitochondria for aerobic production of energy. The immature myocardium reacts to stress situation with a rapid alteration that leads to acidosis, increase in lactic acid, hypoglycemia, and increase of temperature. We have also to remember that these characteristics are perpetuated till the beyond the neonatal period, and there is a gradual transformation that occurs during the first years of life and continues up to the continues again over the 2 years of age, in which we have a complete maturity about 7 years of age. So the key message that I wanted to leave you is myocardial injury is probably related to age, and so probably we should think or rethink to myocardial protection in order to age dependency. This is what they find, the group of Bristol in this quite old, not so old paper, but it's particularly of benefit for this presentation, because this allowed us to see how is the difference between infants and children, in which we have a huge difference, in particularly when we have more than when the ischemic time increase, even if at the baseline we have a difference from between the children and the infant or neonates in terms of duration of a hospital stay, ICU stay, ventilatory support, and time of inotropic support. This is anyway validated by even the analysis of some other markers, in particularly the ischemic stress, even if there is a positive correlation in which we have a fall of ATP ongoing with the cross-count time. But while in this cases the difference is quite low, we can see that in the reperfusion injury, the difference increased with time, and it's the response of children is quite better generally respect to infants. There is this paper is also important to demonstrate, because demonstrated there is a huge difference when we talk about acyanotic and cyanotic patients, in which cyanosis can increase the response in children, while in neonates is quite high anyway. Which are the current evidence that we have? First of all, the cardioplegia practice in pediatric cardiac surgery mainly derived from adults, except the needle solution, and so probably cannot be optimal for immature myocardium in patients with cyanotic congenital heart disease. We have to take in mind that we have generally pragmatic approach to the choice of cardioplegia that depends that is according to surgeon preference, and not all the time surgeons are completely aware of what is myocardial damage and the process that leads to myocardial damage. Of note that we cannot see any change or willing of change unless we have worsening results in the institution, and the outcome evaluation is generally based on institutional policy and not on international guidelines. What is important is that the data of outcome came from in this population, in pediatrics particularly, from retrospective single center case series, and the only randomized control trials evaluating one myocardial protection strategies come in a one-to-one fashion with very small cohort of patients, and generally are single center reports. This is probably what we have to do. So looking forward to meta-analysis that pooling data from randomized control trials can give us some information. This is a recent meta-analysis coming from the group of Birmingham, in which they evaluate CPL solution added in children undergoing cardiac surgery, 26 trial after the PRISMA flowchart evaluation, randomizing almost 1,600 children. Unfortunately, randomized trials are single center, phase 2 and not so late phases, and they require very few patients with a median of 48 patients for each trial. No trial assessed cardioplegia are assessed specifically for cardioplegia in neonates, and the conclusion of the trial was that there was a very high heterogeneity index of patient intervention and reported outcome measure, so that at the end they prohibited any sort of meta-analysis and so any sort of possibility to get data, to take data from this comparison. The overall risk of bias was high in almost 12% of trials, but it was 88% was unclear, so a really very bad result. what does not work in this evaluation? We had different, as we can see on the right part of the slide, with different serum biomarkers to say the measures were inconsistently reported, particularly in terms of time points. They were scheduled. The scheduling of sample collection was very variable, and the inotrope was mainly reported as a binary fashion, so means need inotrope yes or not, and no indication and no information about the dose duration of use and any kind of scores over the different periods. This is another previous meta-analysis of FANG, of the group of FANG, and they evaluate the efficacy of blood versus crystalloid cardioplegia. And this, again, the eligibility of trials was limited to 5 randomized controlled trials, 358 children in total, and they didn't find any difference in troponin EI release over the time point of samples, and no difference in duration of ventilation or length of ICU stay. There was a significantly lower blood lactate post-CPB in the blood cardioplegia group, but with this was this effect disappear once corrected from this trial, considering that the heterogeneity index was very high, and it was confirmed after once tested. No other difference. So no evidence of improvement in reality in myocardial injury between blood cardioplegia and crystalloid cardioplegia. This is another meta-analysis comparing again blood versus crystalloid cardioplegia in pediatric cardiac surgery. Very long period of analysis, 56 studies, 7,700 patients, and variables of outcome where there's one. Again, this meta-analysis evaluated any kind of cardioplegia and any kind of way of infusion. The only bias, considering with in our view, was that the needle solution was not reported, and in any cases we didn't find any great difference except from looking to the forest plot, the troponin at 4 hours, but this effect didn't persist over the time. No other problem, no other difference in the lactates over the time, neither in mechanical ventilation, ECMO usage, inotrope, ICU, hospitalization. So the conclusion was the meta-analysis showed neither cardioplegia modality seems to be superior in terms of clinical outcomes, severity of ischemic injury during the arrest, and overall functional recovery. So how can I understand this heterogeneity? We can look at some survey that has been conducted in the past. This is one of the most renowned that has been conducted by a group in North American has been involved 50 over 100 surgeons from 45 centers. They had response from 56 surgeons, and the survey was focused on cardioplegia formulation, dosage, administration, perfusion strategies. 4 age of groups. What is important is that in North America, the needle is using 38% of cases, while customized solution, that means made in any institutional, was about 32%, and this can explain the difficulty to pull data from different institutions for to have a correct methodology from the methodological point of view of analysis. Just a few information. Cardioplegia was mainly given in a hypothermic way. Systemic colic temperature by age was technically very moved from to the most low temperature in the neonates, while we have moderate to normothermic systemic temperature of the patient in the older age. What is important is that looking at induction dose by solution, and this again demonstrated the problem in reliable data, is that even inside the same solution, we have a very different condition in terms of volume to be delivered for the induction dose, and this can make the difference. And another thing is that considering long-term cardioplegia, the time interval between the dose was incredibly lower than how normally has been indicated for such a kind of solution. We have different strategies with regard to time interval between cardioplegia doses, and there was at the end the perception that the needle and the custodial solution can offer an appropriate myocardial protection for the longer intervals and the necessity to decrease the dose. This is another survey coming from UK and Ireland. From again the group of Birmingham, and it was aimed to establish the current cardioplegia practice in that area, but more the willingness of the authors to randomize the patient for a different cardioplegia solution within a multi-center randomized control trial. 32 cardiosurgeons, 12 head of perfusion in the 12 centers that endorse pediatric cardiosurgery. In this case, St. Thomas modified by Harrifield is the most usage in that area. And of note that Del Nido and Custodial are not available in UK, at least this is information that they report. And even if we have variation in CPL practice, there are some fixed points that are the usage of antegrade cold blood cardioplegia, very few adjustments for patient age and complexity, indicating the total faith in the solution and in the strategy they decide. And they had a frequent redose based more on the timing elapsing since the last dose. According to the idea of try a different solution, almost all responders give their support in changing their practice and support the feasibility of randomized control centers and trials. And what was indicated as the most interesting trials was the investigation with the needle plus St. Thomas by Harrifield, and very, very slow people respond not, they were willing to change the practice. According to this, as a systemic review and meta-analysis that in this case is not an open solution, but is particularly focused on Del Nido and St. Thomas cardioplegia in adults. 7 studies focused on adult and pediatric cardiac surgery, but in any case, 1 retrospective and 3 randomized control trials for pets. Primary outcome in these cases were in a more pragmatic way, clamping and CPB time and defibrillation rate. Secondary outcome, ICU length of stay, acute renal failure, and 30-day mortality, but just for peds. The outcome vary between the population. In peds, we didn't find any difference from clamping time, but they have a lower defibrillation rate observing the needle solution. And this is what is being reported by the group in the forest plot, and in which we can see that in the pediatric cardiac surgery population there were evident benefits for the Del Nido solution, even with a very low index of heterogeneity. So there are some consideration that we have to face phase 2. That is, there are some bias and some future indication. We should report valid outcomes variables that should be comparable, and when we decide for biomarkers, we have to share with we have to decide and try to do a gentleman agreement within a clinical and researcher to have a standardized method in reporting this variable. Cumulative under troponin area under the curve troponin at 72 hours has been shown to be the best predictor for in a midterm myocardial injury, but there are some technical bias. Once in pediatric, we remove central venous catheter to continue to have this sample at up to 72 hours in case everything is was going well. There are some new measures of myocardial injury that can give us early information and have anyway a greater positive predictive values. There are some other indicators like maximum vasoactive inotrope score that is absolutely validated for as an optimal measure according to the needs for pharmacologic cardiovascular support in infants, and it is strongly associated with morbidity and mortality. There are no studies at the moment evaluated long-term outcomes, and this can be argued and then become a matter of discussion. Probably we have to focus on randomized controlled trials on hyperpolarizing solutions that are the most desirable solution in this moment. So concluding, there is a lack of evidence to support the technique over the other. In pes cardiac literature, we have no late phase randomized controlled trial. This is the problem that we have to work on it. Where the only few meta-analyses are based on weak randomized controlled trial with very high risk of bias and high heterogeneity, and this doesn't allow us to pull the data for to obtain guideline or protocols, institutional protocols. Blood-based cardioplegia seems to slightly overcome the crystalloid solution, and Del Nido seems to be the preferable one. We probably have again to investigate furtherly long-term hyperpolarizing cardioplegia like Del Nido and Custodiol. Thank you for your attention.
Thank you, Mauro. It's a very interesting topics, a very interesting presentation. And we have some questions for the speakers, and one question for Mauro Renghini. Mauro, are you come? Okay.
Yes.
Okay. There are one question for you. Mauro, thanks for your presentation. Strong utilization of Del Nido about plegia. Do you use always if aortic cross clamping time exceed exceed 19 minutes, or do you don't do nothing if the heart is still arrested? If you repeat the dose, how much volume do you infuse?
Okay, thank you for this question. Yes, if we have a long clamp time, we reduce the del nido with half doses with 500 milliliters in anterior grade or retrograde of both view. In our experience, the more longer aortic cross clamping is if 3 hours with 3 doses of del nido, and with only single shot doses in the long aortic cross clamp is 150 minutes, and but at the 90 minutes we speak with surgeon and if necessary reduce the cardioplegia or nothing if the heart is still arrested.
Okay. Another questions, and it's do you find necessary to use a demo filter for during the del nido cardioplegia? Also, for the 5% of patients that you don't use del nido solution, what is the reason for this? Is it simply due to surgical preference? Sorry.
Okay. No, in our experience, it's not necessary the use of hemofilter because with the del nido, there is a low part of low hemodulation. We use hemofilter only in patient with renal insufficiency, chronic renal insufficiency, or with in previous surgery pulmonary edema. The doses of del nido is only 1 liter for 80% of our surgery. About me, it's not necessary the hemofilter. In some cases, when the hematocrit is low and we have a more volume in the cardiotomy, we use diuretic. And for the 5% of our patient is a surgeon preference, not surgical, but surgeon.
Surgeon prefer.
Yeah.
Okay. Depend of the surgeon.
Yes. Yeah.
All things. And another questions. Inject pressure the site of a measurement for cardioplegia. Do you measure the pressure during the cardioplegia inside the
Yes.
the root?
Yes.
Okay.
We measure the pressure in aortic root in the case of anterior grade cardioplegia, or retrograde in coronary sinus, or the pressure of circuits in selective ostia.
Okay. And another questions for you, Mauro. Do you practice hot shot when using the needle before cross clamping?
Okay. In our center, only one surgeon does the hot shot before the cross clamping. We don't find any difference in two techniques.
Okay. For one questions about Mauro Cozza for my I have no experience for pediatric case, and I think that it's very difficult to find a right cardioplegia for the pediatric case or for neonatal cases. What do you think? Do you exist the cardioplegia for any cases about for pediatric case, or do you think that do you use you must use the tailor cardioplegia for the pediatric case or for the neonatal cases?
Well, what can I say to you is that we experimented in the past 1-to-2 blood cardioplegia. Then we tried the custodial, but since 2017 or 16, we move definitely to del nido cardioplegia. And we, as you know, we do about 500 congenital cardiac cases and 1,000 cases in adults. And now we start from congenital heart disease cases, and we move step by step. But at the end, in less than 4 months, we moved completely to 100% to the nido cardioplasia. So today we are very satisfied. And the real effect, what is a part of what is matter of the measurement, that is the only law that we have to follow when we have to give a real consistency to evaluation about the efficacy of this solution. What can I say to you is that we didn't find any problem due to inadequate myocardial protection. Reperfusion injury is now a very rare event. I can say we didn't find any critical reperfusion injury in neither in pediatric population as in adult population. So what I can say is that actually, if I have to suggest one solution, is to move toward the nido. And I'm not a fan of using different solutions. This may be confusing the system and also the results.
Okay, thank you. Another question for Dr. Renghini. Do you adapt the dose of the nido CPL in case of hypertrophic heart?
Okay. In cardiac population, the most part of patient have the hypertrophic heart. So we do the all doses for all patient, but in the case of the short clamp time, we do half doses of the nido. But if the patient have a hypertrophic heart and hypertrophic heart and the short cross clamp time, we do the full doses. Only surgery with half doses of the nido. It's the coronary artery bypass grafting or something, or the second clampage for mitral valve or the caval thrombus.
Okay. Okay. Another questions. Del nido and the worm cardioplegia. I don't know. I think that it's you combine del nido and the worm cardioplegia. Mauro, both Mauro Cozza and Mauro Renghini. What do you think about these questions? It's different.
Mauro Cozza.
Mauro Cozza.
Now, what I can say is that reviewing the paper for this presentation, there has been some cases in which some surgeons moved to a sort of worm del nido. What was of particular interest was, on my opinion, the possibility to move toward all blood del nido. That is what is defined the modified del nido. And this is a particularly of interest because if we, as Mauro told before, there is no, it's not mandatory to use hemoconcentrator unless you are treating very small neonates or middle-sized patients. What can I say is that the possibility to reduce edema, even with the presence of the presence of the mannitol hair scavenger system inside the crystalloid solution could be a very optimal possibility. What is probably has to be analyzed is that the solution of del nido has a very low concentration of calcium, as Mauro told before. Blood does not. So using medium, uses of medium cardioplegic medium blood, we have to identify with a really deep analysis what happened inside the cells with this possibility.
Thanks. The last questions, because it's very interesting for me. How often do you find a problem with the reactivity of the heart before repeating dose? Mauro Renghini?
In our experience, we find the reactivity of the heart when the aortic cross clamp time doesn't well done, and this is the only. I remember. I don't remember other time,
repeating.
Yeah.
Mauro, for you?
I agree with him. Absolutely. We never, even in pediatric population, there is a very old, not very old. There is a whole paper about the use the cardioplegia and the reactivity, punching the heart in experimental way on breath. And it was incredible, the difference between standard extracellular solution and hyperpolarizing extracellular solution. It's very rare to experience restart of activity. We generally with the first dose, it's quite enough to obtain total electromechanical quiescence.
Okay. Thank you so much of all, everybody, the speakers. I am very happy to work with you, and thank you for EBCP for opportunity, and thanks Erminia, Mauro Cozza, Mauro Renghini, and all perfusionists in Europe. Thank you so much. Bye bye.
Thank you.
Thank you.
Thank you. Bye everyone.
Bye.